Hi, this is E. David Crawford. During the next few minutes, I want to share with all of you an overview of the Radar 3. I also want to go along and discuss the Radar 1 and Radar 2 and how they led to this now Radar 3 manuscript. So my outline is in the slide. Basically, I will discuss Radar 1 and Radar 2, but the main focus is going to be on Radar 3. We'll talk about next generation imaging. We'll review those modalities, and we'll talk about some of the novel new PET radiotracers and how we feel they should be implemented in the practice of evaluation of patients with prostate cancer. So let's begin with Radar 1. This was published in Urology in 2014, and by the way, is still one of the most downloaded manuscripts in prostate cancer today. The authors are listed here and include a lot of internationally known urologists, medical oncologists, and radiologists who have an interest in prostate cancer. We got together basically because after reviewing guidelines out there, there was really no consensus. And we also noticed that a lot of times there was irregularity in how men were being evaluated with prostate cancer. One of the biggest areas were in men with newly diagnosed metastatic disease who may have a Gleason score of 6, undergo surgery or radiation, and they would get bone scans, CT scans, and so forth. And we thought that that was sort of not a good use of resources. We also saw a lot of people with advanced disease where they weren't imaged enough to diagnose the moment that they developed advanced disease. So our goal here with the Radar group was to review currently available image guidelines and relevant clinical validation studies for metastatic disease and prostate cancer. We did that, and as I mentioned, we found no consensus on eligibility criteria, type of image modality, and frequency of scanning for detecting metastatic disease. We developed a consensus and recommendation among our group, and then we summarized this and, as mentioned, published this in the Journal of Urology. So the summary of the guidelines that we looked at that were out there, there was a prostate working group, American College of Radiology, European group, AUA, European Association of Urology, and the NCCN. All of them had bits and pieces of guidelines for when to use imaging and evaluation of men with prostate cancer. Here is the bottom line we came up with. First of all, we identified 3 areas where we needed to do some work: newly diagnosed patients, men who had biochemical recurrent disease, and men who had M0 castrate-resistant prostate cancer. Our guidelines for newly diagnosed metastatic disease were pretty simple. If you had 2 of any of these 3, you should undergo imaging. And by imaging, we usually meant conventional imaging, bone scans, and CT scans. The PSA level greater than 10, Gleason score of 7 or more, or palpable disease, any 2 of these would mean you should undergo a technetium bone scan and perhaps a CT scan. Biochemical recurrent patients. There are a lot of patients who fail local therapies. We know that probably the best time to do the first scan is when the PSA is between 5 and 10, and the next imaging should be done, if those are negative, when the PSA is double, and every doubling thereafter every 3 months, depending on how closely you're following the patients. When we talk about Radar 3, we'll see that we added on here that you can scan at lower PSA levels, even less than 0.5 in some men, to try to find metastatic disease or location of the disease. The third bucket were in men who had M0, so non-metastatic castrate-resistant prostate cancer. That's what we thought they had, but many of these men will have metastatic disease. So the first scan would be done when the PSA level was greater than 2, and then image, if that's negative, 5, and then every doubling time thereafter. So that was a summary of the Radar 1 guidelines. And so the imaging modalities that we use for the radar group here were technetium or abdominal CT. Back then, there was an interest in sodium fluoride PET, but that's waned. MRI and plain radiography are also other things to think about. So in conclusion, there was an inconsistency in the literature and the current practice of eligibility criteria. As a result, there is underdiagnosis of metastatic disease. And we think metastatic disease is a seminal event, and there's a value to identify it early. There was consensus and recommendation to promote early identification of metastatic disease because we have a lot of new drugs, protocols, and things like that where clearly a benefit is available when you have metastatic disease and find it early. The objective was to improve patient management and facilitate our treatment practices. And of course, early detection of metastatic disease was Radar 2's job basically was therapeutic layering. This is a term we came up with to discuss how we would layer all these new drugs. And we had many of the same authors that we had with the Radar 1 manuscript. So our objective of Radar 2 very simply was to provide a consensus on sequencing, combination, and therapeutic layering. So let's talk about the differences between these various terms. Combination therapy is when two or more therapies are initiated simultaneously. So we see a lot of that on oncology. We sort of do that with prostate cancer with an LHRH agonist or antagonist and an anti-androgen. Therapeutic layering, as we defined it and came up with that term, represents a clinical point where one or more agents are added onto an existing therapy. So ADT is given, patients failing, we might add abiraterone, enzalutamide, cipralesyl T, many of the new drugs I will discuss, and maybe continue those, because that's called therapeutic layering. And then castrate-resistant disease, we'll talk a little bit about that, and later in Radar 3 about some new terminology to deal with. So the opportunities for therapeutic layering are basically, we do this all the time. Androgen deprivation therapy, best supportive care, always sort of exists when we have metastatic prostate cancer, particularly castrate-resistant. And what we see is you can add on immunotherapy, targeted alpha therapy, that's radium, chemotherapy, second generation androgen pathway inhibitors. These would be things like anti-androgens and androgen biosynthesis inhibitors. And we sort of have this asymptomatic and then symptomatic metastatic castrate-resistant prostate cancer that exists out here. So what we were trying to do was there's a benefit to combining agents. Unfortunately, we don't have a lot of data and randomized trials. We know in many cancers, for instance, lymphomas, that CHOP therapy, 3 or 4 drugs, testis cancer, 3 drugs, platinum-vilbane bleomycin, leukemias. It's combination therapies or layering that makes the advantage, not treatment A followed by treatment B followed by treatment C. So the most effective sequence and combination of therapeutic layering, this was basically a consensus, was that androgen pathway inhibitors are the easiest agent to layer onto ongoing trials with chemotherapy. Radium also is a good drug to use early. Unfortunately, many times we hold it to the end. Cipralesyl T is a marvelous drug that can successfully be administered early, along with abiraterone and enzalutamide and things like that. So these things are all important, and we have lots of options to think about. So in conclusion, despite great strides in MCRPC, selecting treatment to optimize outcomes remains a challenge. We have many different agents which are unique and complementary mechanisms of action to avoid cross-resistance. Optimal treatment selection may depend on molecular characterizations, genotyping, as well as clinical characteristics. And we're seeing a lot of that right now, and many of us are familiar with the ARV7 mutations and tests to identify those. Clinical trials remain important. We should support those. We should work at combining things. And in the last few months, we have seen this, particularly with metastatic disease. We've started out several years ago with Charted, and then Latitude, and now Titan and Enzymit, and a whole bunch of new studies that show combination and layering and continuing the ADT matters in men with advanced prostate cancer. So let's move to Radar 3. Radar 3 was, we got together to discuss this, basically because of the introduction of next generation imaging, which we'll discuss here in a minute. So Radar 3, our objectives was to gauge the rapidity and ease of uptake of these novel imaging agents among medical oncologists and urological oncologists, to redefine the existing terminology that does not represent the changing landscape in biochemical recurrent non-metastatic disease. So considering altering the castrate-resistant term to endocrine-resistant term, and we'll talk about that in a minute, and also to update Radar 1, those 3 buckets that I just showed you, on what next generation imaging will do when we add that to those buckets. The new scanning agents are listed on this slide, and these include fluciclovine, the PSMA gallium. These are the 2 most common ones used in the US right now. Not so much PSMA gallium, but soon we have choline and acetate PET and other things out there that are good scanning agents, but the issue is that they're not readily available. So what we have here are some studies that have been done and in the literature on the various agents that are out there. These include choline, PSMA, and fluciclovine, which I mentioned. At least fluciclovine or Oximum scan is one of the most common ones used in the United States. And what we see is that most of these are done with men with biochemical recurrence, and it looks at the sensitivity of the test, percent with positive relative to PSA. And the higher the PSA, the more positive it is. But a couple of them are very good at identifying men with low PSAs and detecting disease. So the next thing we get concerned about is third-party payer coverage. And what we see here is that fluciclovine or Oximum scan is covered by Medicare. C-choline PET is too. Sodium fluoride PET, I mentioned this earlier, is not. It was studied and it was determined that it wasn't going to be covered. And the last one is the gallium, and gallium is currently being studied in the United States, and probably within a short period of time here, we'll see that gallium is available for use in the United States. So let's talk a little bit about terminology. Our recommendation, and we realize this is sort of controversial, is now to name these states ERPC instead of CRPC. We think that better reflects what's going on with the tumor, and it also sort of updates it because, well, now we can add and include the next generation imaging on top of things we've already used, technetium and scans and MRIs, and we can now call it, next generation imaging evaluation. So we would somebody that had biochemical recurrence and progression and negative conventional imaging, so that would be somebody who's been on hormone therapy, their PSA goes down after having radiation or surgery, but starts going up, and you image them with conventional imaging, which would be bone scans, CT scans, things like that. We would call that NMERPC if they're negative, and if they have a next generation imaging, we would add a asterisk to that to identify this was imaging that was determined to be non-metastatic rising PSA with the use of next generation imaging. You could add a similar, just a asterisk to the MECRPC when there was the presence of next generation imaging. So our recommendations basically are Radar 3 recommends utilization of traditional scans with consideration of NGI only if traditional scans are equivocal or negative and the clinician still suspects progression based on various factors or a higher stage disease. So, but this is things that we use: are Gleason score, PSA velocity, and patients that have NCCN, very high risk or locally advanced disease, should be considered for NGI initial diagnosis. But let's look at a case. For instance, we have men that we see all the time have PSAs of 70, Gleason scores of 8, and they have no metastases on technetium scan. We know those people do. This would be a good place to use next generation imaging. So let's look at our final slide here on our recommendations. So what we did, Radar 3 expands Radar 1. We talked a little bit about the Radar 1 a few minutes ago, as we have sort of the 3 buckets: newly diagnosed, biochemical recurrent, and M0. And now we've added M. In general, we don't need next generation imaging. Follow these guidelines. But as I mentioned, if we have a guy that we strongly suspect would have metastatic disease or nodes, this guy with PSA of 80, Gleason score of 8, and negative imaging, this would be a good place for next generation imaging with one of the 2 modalities that are out there right now in the U.S. Biochemical recurrent patients, we've talked about that. When to do the first PSA, scan when PSA was 5, and then again at 10. And so now we feel that we can, in some people, where it would be actionable to do something when the PSA is less than 0.5, we might even consider it. But right now, we're just saying that consider NGI when it's above 0.5. Some of the imaging can go down even lower to detect disease. The M0 castrate-resistant patients only consider NGI in this setting when the PSA doubling time is low and when you suspect there might be metastatic disease and the other conventional imaging is negative. And finally, M1 castrate-resistant disease, not a big place, but utilize conventional imaging. But again, if we feel that this is letting us down, we have other signs like rapid doubling time, things like that, change in symptomatology, performance status that we can't reflect on a normal, rather on a technetium scan. Next generation imaging might be helpful here. So finally, in conclusion, what we can say is while traditional CT, MRI, and bone scans still have a role in initially diagnosing prostate cancer, we're excited about next generation imaging modalities. They're more sensitive for visualizing advanced prostate cancer. They're recommended in select patients where aggressive intervention earlier may be indicated. Rising PSAs at low level, men who have non-metastatic castrate-resistant disease, where it might be best in our guidelines, as we said, to use something like this. But our strongest recommendation for the use of NGIs in patients that are biochemically recurrent prostate cancer with lower PSAs than you could detect with regular scanning. Remember, we said PSA and 5 level at least start out with. So we could start out with less than 0.5 or 0.5 or above or something. These are where the data are the strongest and likely where self-directed therapy would help patients. But it would be if we find something that's actionable, lymph nodes, things you could radiate, take out, and so forth. And basically what we're trying to do is to improve patient outcome. So very briefly, in the last few minutes, I summarized the Radar program: Radar 1, Radar 2, therapeutic layering, and now Radar 3. We are going to have another Radar 4, which is going to be based on methodology, scanning, and that to avoid metastatic castrate-resistant prostate cancer. I thank you for your time.